Welcome back to the deep dive. Today, we're doing something a little different. We are shifting gears. We're not just exploring a topic. We are really stepping into the arena.
We are.
We're going to simulate a high-intensity, high-stakes preparation session for the MD anesthesiology exams. Now, we're looking at this specifically through the lens of the Gujarat University curriculum, but honestly, the principles we're going to cover today, they apply to any rigorous anesthesia board exam.
Oh, absolutely. Any theory paper.
So if you are a resident and you're feeling the heat of those exams coming up, or maybe you're just a practitioner who wants to sharpen your autonomic pharmacology, you are in the exact right place.
It's good to be here. And you are absolutely right to frame this as high stakes.
It really is.
In the MD exams, especially at a level like Gujarat University, the examiners have a very low tolerance for vague answers. There's just no room for general ideas or, fluff.
Right.
You need specifics. You need the molecular mechanisms. You need precise dosages. And maybe most importantly, you need that clinical correlation. You have to show you can think like a consultant, not just memorize like a student.
Exactly. And to do that, we're tackling a drug today that is a certified exam favorite. It is the classic molecule that sort of bridges that gap between basic pharmacology, pain management, and critical care.
Yeah.
We're talking about Clonidine.
Clonidine, the old warhorse. It's funny. Everyone in the modern OT is completely obsessed with Dexmedetomidine these days.
The shiny new toy.
It is. It's titratable. It's expensive. It's the new thing. But the examiners, they absolutely love Clonidine.
So why is that? Why is that preference there? Is it just nostalgia for the old days?
No, not at all. It's actually very tactical. It's because Clonidine is the perfect litmus test for your understanding of the autonomic nervous system. I mean, think about it. If you can explain Clonidine properly, you prove you understand receptor selectivity. You prove you understand G-protein-coupled cascades, and you understand that delicate physiological balance of sympathetic versus parasympathetic tone.
So it's a proxy for your fundamental knowledge.
It is. And plus, just practically speaking, it is a 20-mark long answer question just waiting to happen.
Okay, that is our mission then. We are going to build from the ground up the perfect 20-mark answer. We've got our holy trinity of sources here.
The essentials.
We got Katie Tripathi for that gritty pharmacology mechanism, Miller and Stolting for the anesthetic depth, Morgan for the clinical practicality, and we've pulled notes from Kaushik Jyothinath for those really specific dosages and regional anesthesia nuances.
That is the gold standard source list. There's nothing more you need. So let's structure this discussion exactly how a candidate should write it in their theory paper.
Let's do it. Let's dive in. Section 1, Introduction and Exam Framing. So imagine I open my question paper, and there it is, question 1. Discuss the pharmacology, mechanism of action, and anesthetic implications of Clonidine. How do I start without just sounding generic?
You start with a precise, high-impact definition. Do not just write, it is an antihypertensive. That is undergraduate-level stuff.
Okay, so what do I write?
You write, Clonidine is an imidazoline derivative that acts as a selective, partial alpha-2 adrenergic agonist.
Okay, let's break that down. Imidazoline derivative, that's the chemical structure. Why does that specific term matter so much?
It matters because, as Katie Tripathi points out, apart from the alpha-2 receptors that everyone knows about, Clonidine also acts on imidazoline receptors, specifically the I1 receptors in the brainstem.
Okay.
And this action contributes significantly to its hypotensive effect. So by saying imidazoline derivative in your first sentence, you are signaling to the examiner that you know it has a dual mechanism of action. You're already ahead.
Got it. It's a buzzword that shows depth. And functionally, how do we classify it?
It's classified as a central sympatholytic. That is the key phrase to underline, both literally and figuratively. It reduces sympathetic outflow from the brainstem to the periphery. It essentially turns down the master volume dial of the sympathetic nervous system.
I like that analogy.
Yeah.
And strictly regarding exam relevance, why is this topic such a potential minefield? Or, an opportunity?
Because it is so versatile. They can ask it in 3, maybe 4 distinct ways. First is the long answer we're prepping for right now, the big 20 marker.
Right.
Second, it could be a short note. Often it's very specific, like Clonidine as an adjuvant in regional anesthesia. And third, the Viva voce. In the Viva, they will not ask you the basics. They assume you know that. They will grill you on the traps.
The traps.
The traps, things like rebound hypertension, the exact selectivity ratio, and why you can't just use it with any beta blocker. They want to see if you can think on your feet about safety.
Okay, let's get into those weeds then. Section 2, Pharmacological classification. You mentioned it's an alpha-2 agonist, but it's not purely alpha-2, is it? You just said it has some other action.
No, it's not. And this is a critical distinction for the exam. The term is selective, but not specific.
Okay, what's the difference?
According to both Stolting and Morgan, Clonidine has an alpha-2 to alpha-1 selectivity ratio of approximately 220 to 1.
220 to 1. I'm writing that down. That seems like a number I need to know.
It is a number you absolutely must know, and you have to contrast it. The newer agent, Dexmedetomidine, has a ratio of about 1620 to 1.
Whoa, okay, that's a huge difference.
It's a massive difference. So, relatively speaking, Clonidine is a dutier drug. It stimulates alpha-2 receptors 220 times more avidly than alpha-1, but that little bit of alpha-1 activity is still there. It hasn't gone away. And it plays a role in some of the side effects, like that transient vasoconstriction we'll talk about.
Right, so when we classify its action, we divide it into central and peripheral. Can you clarify that split for us?
Precisely. The central action is the major one. That's the main event. It acts on the brainstem, specifically the vasomotor center in the medulla and the locus coeruleus. This is what causes the sedation and the drop in blood pressure.
Okay, that's the central part. And peripheral?
The peripheral action is primarily on the presynaptic nerve endings.
Presynaptic, that's the key location, right?
Yeah.
Before the synapse.
Yes, that's the critical word. Stimulation of these presynaptic alpha-2 receptors acts as a negative feedback loop. It's like the nerve terminal has a sensor. It tells the nerve, hey, we have enough norepinephrine out here in the synapse, stop releasing more.
So it's a double whammy.
It is a double whammy on the sympathetic system. The central action decreases the go signal from the brain, and the peripheral action inhibits the release of the neurotransmitter at the nerve terminal itself.
That leads us perfectly into section 3.
Yeah.
Mechanism of action. This is what you call the exam core. I feel like if a candidate messes this up, they fail the question regardless of how much they know about doses.
I completely agree. This is where the marks are. The examiners want to see that you understand cell membrane physiology. You cannot just say it binds to the receptor. That's not enough. You have to explain the G protein cascade. You need to be able to draw the diagram in your head and ideally on the paper.
Okay, so walk me through the molecular journey. Clonidine, the molecule, arrives and binds to the alpha-2 receptor. Then what happens?
Okay. So the alpha-2 receptor is a transmembrane G protein coupled receptor. Specifically, it's linked to the G protein. That I is your first clue. That stands for inhibitory.
Inhibitory. Got it.
When clonidine binds, the alpha subunit of this G protein dissociates and it travels along the membrane to inhibit the enzyme adenyl cyclase.
Yeah, adenyl cyclase. That's the enzyme that manufactures cyclic AMP, right?
Correct. So inhibition of the enzyme leads to a reduction in intracellular CAMP, which is cyclic adenosine monophosphate. That is step 1, but that's just the biochemistry. For the Viva and for the full marks, you need to talk about the ion channels. This is the so what of the mechanism. This is what actually changes the cell's behavior.
This is where we get into the potassium and calcium.
Exactly. The activation of that J protein leads to 2 massive changes in ion conductance across the cell membrane. First, it activates or opens inwardly rectifying potassium channels.
Okay.
Now, you remember your basic physiology. Potassium is highly concentrated inside the cell. So when you open the door for it, potassium rushes out of the cell down its concentration gradient.
And when all that positive charge leaves the cell,
The inside of the cell becomes more negative. It becomes hyperpolarized. A hyperpolarized cell is stubborn. It's unresponsive. It's much harder to excite. That's how you get sedation and inhibition of nerve firing.
okay, that explains the potassium side of the story. What about the calcium?
It does the opposite, in a way. It inhibits voltage-gated calcium channels. Specifically, the N-type channels are the important ones here. Now remember, calcium entry into the nerve terminal is the absolute trigger for neurotransmitter vesicles to fuse with the membrane and release their payload into the synapse.
So if you block the calcium from getting in,
You block the release of the neurotransmitter. It's that simple. No calcium, no exocytosis, no signal being passed on.
so just to recap the whole mechanism for our listeners so they can lock it in, clonidine hits the alpha-2 receptor.
Right.
That activates the G-bri protein,
The inhibitory one.
which causes GMP to go down. And then at the channel level, potassium channels open, making the cell hyperpolarized and hard to fire.
Correct.
And calcium channels close, which stops the nerve from releasing its neurotransmitters.
Perfect. And you must mention the specific sites of action from a textbook like Miller to get the full marks. Site 1, the locus coeruleus in the brainstem. This is a sleep and arousal center. Reducing firing here is what causes that characteristic sedation.
Okay. And site 2?
Site 2. The dorsal horn of the spinal cord, specifically an area called the substantia gelatinosa. This is the pain gate.
Ah, the pain mechanism.
This is it. It inhibits the release of nociceptive neurotransmitters like substance P and glutamate from the primary afferent fibers. That's the presynaptic effect. And it also hyperpolarizes the second-order neurons. That's the postsynaptic effect. So it blocks the pain signal at 2 points.
And didn't Morgan mention a peripheral nerve effect too? Like directly on the nerve?
It does. It has a mild local anesthetic-like action. It can actually block conduction in C fibers and A delta fibers, which are your primary pain fibers. And that explains why adding it to a peripheral nerve block actually worked. It's not just systemic absorption.
Okay, that is a rock-solid mechanism section. Let's move to section 4. Pharmacokinetics. This is another area where, a book like KD Tripathi is the Bible. What are the headline numbers we need to remember?
Absorption is the first point, and it's a good one for clonidine. It's incredibly well absorbed. The oral bioavailability is very high, somewhere between 75 to 95%, so you can say nearly 100% in an exam context.
So if you give it orally as a pre-medication,
you're going to get peak plasma levels in about 2 to 4 hours. If you give it IV, obviously it's much faster. You're looking at an onset of around 10 minutes.
What about lipid solubility? That's always important for drugs that need to get into the brain.
Very high lipid solubility. And that's exactly why it crosses the blood-brain barrier so rapidly and causes that profound central sedation we talked about. It just slips right through.
Now, for metabolism and elimination, I have a note here about a 50-50 rule. Is that a good way to remember it?
That is a fantastic mnemonic for the exam. Simple and accurate. Approximately 50% of a dose of clonidine is metabolized in the liver. The other 50% is excreted completely unchanged in the urine.
Okay, why is that unchanged in urine part so clinically important? I feel like that's a potential danger zone.
It is because of renal failure. And Kaushik Jothanath specifically highlights this point. If a patient has renal failure, or even just significant renal impairment, they cannot clear that 50% of the active drug. It just builds up.
So a standard dose could be an overdose.
Exactly. A standard dose in a dialysis patient can lead to profound, prolonged sedation and refractory hypotension that's very hard to treat. You absolutely must reduce the dose.
And the half-life, how long does it stick around?
Roughly 8 to 12 hours. And this is a crucial comparison point for the exam. Dexmedetomidine has a half-life of only 2 to 3 hours. Clonidine sticks around for a long time. That can be good for long-term analgesia, but it's very bad if you want a patient to wake up quickly after a short procedure.
Right. That makes sense. Which leads us nicely into section 5, pharmacodynamic effects.
Yep.
So we all know it lowers blood pressure, but how exactly do we describe the cardiovascular effects to sound like we know what we're talking about?
You need to break it down mechanistically, not just state the effect. So for hypertension, you say it occurs via central inhibition of sympathetic outflow that's turning down that master dial we talked about.
And there's a kidney effect too, right?
Yes. It also decreases renin release from the kidney, which then lowers blood pressure via the renin-angiotensin system. For bradycardia, it's a two-part answer. You are decreasing the sympathetic drive to the heart's pacemaker, and you're leaving the parasympathetic or vagal tone unopposed, so the heart rate naturally drifts down.
Now, KD Tripathi warns about a very specific trap here related to giving it intravenously, the transient hypertension phenomenon.
Yes, this is a classic exam trap. If you inject clonidine rapidly IV as a bolus, you might actually see the blood pressure go up, sometimes significantly before it crashes down.
That seems completely counterintuitive. You're giving an antihypertensive and the pressure spikes? What is the physiology there?
It goes right back to that selectivity ratio we discussed, the 220 to 1. When you push a bolus of IV, you get a very high concentration of the drug in the peripheral blood before it has had time to distribute and cross the blood-brain barrier.
Okay.
At those very high initial concentrations, clonidine stimulates the peripheral alpha-2b receptors, and these are located directly on the vascular smooth muscle.
And alpha-2b on blood vessels causes vasoconstriction, not vasodilation.
Exactly, causes a squeeze. So you get a transient vasoconstriction and the pressure spikes. Then, as the drug distributes into the CNS, that powerful central sympatholytic effect takes over, vasodilation occurs, and the pressure drops, usually lower than where it started. But examiners love to ask about that initial spike to see if you understand peripheral versus central dynamics.
Got it. So peripheral vasoconstriction first, then central relaxation.
Yeah.
Okay, what about the CNS effects?
Two main ones, sedation and anxiolysis. And as we said, the sedation it produces mimics physiological sleep. It's mostly non-REM sleep. So the patient is asleep, but they can be easily aroused to voice or touch. This is very different from, say, a GABA agonist like propofol or a benzodiazepine where the patient is properly attended.
Right. And what about the overall anesthetic requirement? How does it impact that?
It is remarkably MA sparing. Morgan's textbook notes that clonidine administration can reduce the requirement for volatile anesthetics, the MSI value, by up to 40–50% in some studies. And it massively reduces your opioid requirements. It just facilitates a much smoother, more stable anesthetic course.
Okay, let's move on. Section 6, clinical uses in anesthesia. We're building the clinical part of our answer now. I guess premedication is the classic old-school use.
It absolutely is, and it's still very relevant. Kaushik Jyothanath suggests a dose of around 2.5 to 4.5 micrograms per kilo, given orally an hour or two before surgery.
And what are the goals of giving it as a pre-med?
The goals are threefold. First, exulysis, just to calm the anxious patient. Second, it dries up secretions because it's an anti-sialagogue acting on alpha-2 receptors on salivary glands. And third, and most importantly, it blunts the stress response to laryngoscopy and intubation.
That blunting of the stress response is huge. It stops that big spike in heart rate and blood pressure when the laryngoscope goes in.
Exactly. It stabilizes the hemodynamics right when they are most labile. It basically prevents that massive catecholamine surge associated with intubation and the surgical incision. It's also used intraoperatively as an adjunct to general anesthesia, again, to reduce induction agent and opioid requirements.
What about in the ICU? Do we still see it used for ICU sedation?
You do. It is useful, especially for facilitating weaning from ventilation, mainly because it doesn't cause respiratory depression. But, practically speaking, dexmedetomidine has largely taken over that role in the ICU, mostly because it's easier to titrate with a continuous infusion.
So it's more controllable.
Much more controllable. But if you're in a resource-limited setting, oral clonidine is a fantastic, cheap, and effective way to settle an agitated patient in the ICU who's fighting the ventilator.
It's also used for induced hypotension, right? I'm thinking of surgeries like ENT or neurosurgery where you need a clean field.
Yes, to provide a bloodless surgical field. It's actually a very good choice because it tends to preserve tissue perfusion better than some of the more aggressive vasodilators like sodium nitroprusside. It lowers the pressure by lowering the sympathetic tone, which is a more physiological way of doing it.
Okay, let's zoom in on a really important area. Section 7, clonidine in regional anesthesia. Our outline has this marked as very high yield.
It is. This is where you can really pick up the extra marks that separate a pass from a distinction or a gold medal. You can put clonidine in almost any regional block, and the examiners will expect you to know the doses and the benefits.
Let's start with neuraxial, then spinals and epidurals. How does it work there?
In a spinal block, so intrathecally, it acts synergistically with your local anesthetics. It works directly on those dorsal horn alpha-2 receptors we drew in our imaginary diagram earlier.
And the dose? It must be tiny.
It's very small. Stolting suggests intrathecal doses of around 15 to 40 micrograms. That's micrograms, not milligrams. You just add that tiny amount to your bupivacaine in the syringe.
And what does it actually do to the quality of the spinal block?
It prolongs it dramatically. It prolongs both the sensory block, the pain relief, and the motor block. According to Morgan, it can add approximately 2 hours to the duration of analgesia. It also seems to improve the quality of the block. The block feels more dense, and patients are more comfortable.
That's a huge benefit, 2 extra hours of pain relief. What about in epidurals?
For epidural use, the doses are higher just because of the larger volume and space. We're talking more in the range of 75 to 150 micrograms. And again, the effect is to intensify the analgesia, which lets you use a lower concentration of local anesthetic. This can help spare the motor block if you want something like a walking epidural for labor analgesia.
And for peripheral nerve blocks, I'm thinking like a brachial plexus block for arm surgery or a caudal block in kids.
It's fantastic for those. For caudal blocks in children, Kaushik Jyothanath mentions 1 microgram per kilogram is the magic number to remember. It significantly prolongs the analgesia after the surgery is over. The kids wake up pain-free, and more importantly, they stay that way for hours.
What's the mechanism there? Is it still the dorsal horn?
Well, the mechanism for peripheral blocks is thought to be a bit different. Miller suggests it involves blocking hyperpolarization activated cation currents or I currents directly in the nerve. It's essentially keeping the nerve in a non-conductive state for a longer period.
But there have to be side effects to putting it in the back, right? It can't be a free lunch.
No, absolutely not. And that's a key safety point. even with neuraxial administration, you are going to get some systemic absorption. Plus, the drug can spread rostrally or upwards in the cerebrospinal fluid to the brainstem. So hypotension and bradycardia are still major risks. You have to monitor the patient just as closely as if you gave it intravenously.
Okay, that's crucial. Let's move to Section 8. Advantages. So if I'm in the Viva and the examiner asks me, why should I reach for Clonidine instead of just giving more fentanyl? What's my answer?
Your number one advantage, your headline, is the opioid-sparing effect. It provides significant analgesia without the horrible side effect profile of opioids. So without the respiratory depression, without the nausea and vomiting, and without the itching.
That really is the holy grail in anesthesia, isn't it? Meaningful analgesia without respiratory depression.
It is exactly that. It allows for what we now call multimodal analgesia. You're hitting pain from different angles. It also provides that hemodynamic stability we keep coming back to. And here's a niche benefit from Kaushik Jathanath that is a fantastic Viva point. Anti-shivering.
Oh, that's a good one. Shivering is a huge problem under spinal anesthesia. Patients hate it.
They do, and it increases oxygen consumption. Clonidine is very effective at treating post-spinal shivering. It's thought to work via alpha-2b receptors in the hypothalamic thermoregulatory center. So if they ask, how do you treat shivering? Clonidine is a very sophisticated answer alongside the classic pethidine.
Good to know. Now we have to cover the dark side. Section 9, adverse effects. We've touched on some of them, but let's list the big ones for the exam paper.
The big two are bradycardia and hypotension. You must respect these effects. If the patient is even slightly hypovolemic, Clonidine will absolutely tank their blood pressure.
Why is it so bad in hypovolemia?
Because that patient is relying entirely on sympathetic vasoconstriction to maintain their pressure. They're clamped down, Clonidine comes in and just takes that compensation away completely.
What about sedation? Is that always an advantage?
No, it can be a disadvantage. It can be prolonged. Because of that long 8 to 12-hour half-life, a patient might be very sleepy for a long time in the recovery room. That's a clear disadvantage compared to dexmedetomidine if you want a fast turnover and quick discharge.
And Katie Tripathi mentions a very specific, common but annoying side effect.
Xerostomia, dry mouth. It is very, very common. Patients will complain that their mouth feels like sandpaper. It's annoying for them, but it's usually transient.
Okay, now we have to talk about the really scary one, rebound hypertension.
This is critical. This is not a side effect. This is a life-threatening complication. If a patient is on chronic Clonidine therapy, taking it every single day for blood pressure, and you suddenly stop it. Let's say you make them NPO for surgery and you forget to give them their morning dose.
Right.
About 18 to 24 hours later, they can go into a severe hypertensive crisis.
Why does that happen? What's the actual mechanism?
It is a classic case of receptor upregulation. The body gets used to having the alpha-2 break on all the time. So to compensate, the body physically creates more adrenergic receptors, and it sensitizes them. It's desperate for a signal.
So when you take the drug away?
When you suddenly take that break away, the sympathetic nervous system floods those upregulated hypersensitive receptors with a storm of catecholamines.
And clinically, what does that look like?
It looks exactly like a pheochromocytoma crisis. Severe tachycardia, blood pressure through the roof, anxiety, sweating, tremors. It is a true medical emergency.
That's terrifying. Okay, so that leads into Section 10. Contraindications. When do we just say no to Clonidine?
Hemodynamic instability is the absolute main one. Do not give it to a patient in shock or severe hypovolemia. Also, be extremely careful in patients with severe heart block, like a second or third degree block or sick sinus syndrome. You will just make their bradycardia dangerously worse.
What about important drug interactions?
The big one that Katie Tripathi warns about is concomitant beta blockers. And this is a nuanced point. If a patient is on beta blockers and you withdraw their clonidine, the rebound hypertension can be even worse.
Wait, why worse?
Think about the receptors. The beta blockers are blocking the vasodilatory beta-2 receptors in the muscle beds. This leaves the alpha-1 vasoconstrictor receptors completely unopposed to that catecholamine storm. It is an absolute recipe for a stroke.
Unopposed alpha stimulation. Got it. And naturally, as we said, renal failure requires a dose adjustment, and you have to be careful in the elderly.
Correct. In elderly patients, the baroreceptor reflex is already blunted. Clonidine blunts it even further. They are very, very prone to orthostatic hypertension and falls. You have to start with a much lower dose.
Okay, Section 11. A quick comparison with other alpha-2 agonists, specifically the big showdown, Clonidine versus dexmedetomidine. How would I lay that out?
For the exam, you should be able to draw a simple table or list the contrasts. So 0.1 is selectivity. Clonidine is 220 to 1. Dexmedetomidine is 1620 to 1. So Dex is a super selective agonist, which means fewer alpha-1 related side effects.
Okay, what's point 2?
Efficacy. Dexmedetomidine is a full agonist at the receptor, whereas clonidine is only a partial agonist. So Dex has a higher ceiling of effect. It can produce more profound sedation and analgesia.
And the kinetics are different.
Massively. Point 3 is half-life. Clonidine is long, 8 to 12 hours. Dex is short, 2 to 3 hours. This makes Dex highly titratable, which is point 4. You can run it as an infusion and turn it on or off. You can't do that with oral clonidine.
And the final point, which is very practical.
Point 5 is cost. This is a huge point for the Indian context and a smart thing to mention. Clonidine is incredibly cheap. It's pennies. Dex is very expensive. In a rural or resource-limited setting, clonidine is the reliable workhorse you will actually have in your drug cupboard.
Right. Section 12. Let's talk bigger picture. Anesthetic and ICU implications. We're starting to see it pop up in modern protocols like OFA.
Yes, opioid-free anesthesia, or OFA, protocols rely heavily on alpha-2 agonists. Clonidine allows you to dramatically reduce or even eliminate intraoperative opioids. And this is the cornerstone of ERAS, or Enhanced Recovery After Surgery protocols.
How does that help with enhanced recovery?
It's simple. Less opioids means less postoperative nausea and vomiting, better gut motility, and that means patients can eat sooner and be discharged faster. There's also some evidence it modulates the surgical stress and immune response better than opioids do.
And there's that quirky diagnostic use you mentioned from Kaushik Jothaneth for pheochromocytoma.
Yes, the clonidine suppression test. This is just brilliant physiology. In a normal person, or even someone with essential hypertension, if you give them a dose of clonidine, their plasma norepinephrine levels will drop because of that negative feedback loop we keep talking about.
Makes sense. It turns off the system.
But in a patient with a pheochromocytoma, the tumor is just churning out catecholamines autonomously. It doesn't care about any feedback loop. Clonidine will not shut it up. So if you give clonidine and the patient's norepinephrine levels do not drop, that is highly indicative of a pheochromocytoma.
That is a brilliant diagnostic pearl to drop in a Viva exam. Okay, we're getting close to the end. Section 13. Common exam questions and Viva traps. What are the examiners specifically trying to trip us up on?
Trap number 1, and they ask this all the time. Does clonidine cause respiratory depression? The answer you must give is generally no, not when used alone. If you say yes, you'll lose points. It might shift the CO2 response curve slightly to the right, but unlike opioids, it leaves the fundamental respiratory drive intact. That is its single greatest advantage.
Okay, trap number 2.
Why does a rapid IV bolus of clonidine cause hypertension? We've covered this, but you need to be precise. The answer is direct stimulation of peripheral postsynaptic alpha-2b receptors leading to vasoconstriction, which precedes the central sympatholytic effect. You must be specific about the receptor subtype 2b.
Got it. Alpha-2b. And trap number 3. How do you treat rebound hypertension?
This is a life-saving answer. Do not use a beta blocker alone to treat clonidine withdrawal. I cannot stress this enough. If you block the beta receptors, which cause vasodilation, you leave the alpha receptors, which cause vasoconstriction, completely unopposed. The blood pressure will skyrocket even further.
So what do?
You treat it by restarting the clonidine immediately. If you can't, you use a combined alpha and beta blocker like labetalol, or a pure alpha blocker like phentolamine first before even thinking about a beta blocker.
That's a critical safety point. Okay, section 14, diagrams. We're writing a 20-mark answer. We need visuals to break up the wall of text. What do we draw?
You need 2 simple, clear diagrams. Diagram 1 is the synapse. You draw a presynaptic nerve terminal, draw the alpha-2 receptor on its membrane, show the clonidine molecule binding to it, then draw the G protein being activated. From there, draw a big minus sign going to a calcium channel showing it's blocked, and a plus sign to a potassium channel showing it's opened. Then show that this leads to fewer vesicles of norepinephrine being released.
Okay, that covers the mechanism. What's the second diagram?
Diagram 2 is the brainstem and spinal cord. Just draw a rough cross-section of the brainstem and label the locus coeruleus, and next to it write sedation and hypnosis. Then draw a cross-section of the spinal cord, label the dorsal horn, and write analgesia. These visuals prove you understand the anatomy and physiology far better than a page of dense text ever could.
Excellent advice. Finally, section 15. Summary and exam conclusion. How do we wrap up this perfect answer to get that 20th and final mark?
You need a short, sharp, bullet point recap of the high yields to leave a lasting positive impression on the examiner who's tired from marking papers all day.
Give me the bullet points. Classification. Alpha-2 partial agonist with a 220-to-1 selectivity ratio.
Action: central sympatholysis causing sedation and hypotension, and peripheral presynaptic inhibition causing analgesia.
Mechanism: G-protein cascade leading to decreased AMP, opening of potassium channels, and closing of calcium channels.
Doses: remember a few key ones. Premedication dose is around 3 to 5 millisiedecal/jam. Intrathecal dose is around 15-40 millisiedegrams.
Key benefit: it prolongs neuraxial blockade and provides excellent opioid-sparing analgesia.
Key risk: you must be aware of rebound hypertension on withdrawal and the risk of hemodynamic collapse in a hypovolemic patient.
That's a perfect summary. And the final closing thought, the last sentence of the essay.
You conclude by saying something like, Clonidine remains a versatile and valuable workhorse in the modern anesthetist's toolkit. Mastering its pharmacology demonstrates a deep understanding of autonomic physiology, not just drug dosages. It is a drug that demands respect for its hemodynamic effects, but offers immense utility in multimodal pain management and perioperative optimization.
That is a comprehensive, exam-crushing deep dive. We have covered the pharmacology, the mechanisms, the clinical uses, and all the traps. To everyone listening, especially those of you prepping for the Gujarat University exams, good luck. And maybe go grab a piece of paper and practice drawing that G-protein cascade right now while it's fresh in your mind.
Absolutely. The difference between a pass and a distinction is often the clarity of your mechanism explanation. Be precise, be confident, and good luck.
Thanks for listening to the deep dive. We will catch you on the next one.